we beat out people like Harvard and Stanford, believe it or not. We just don't tell people very much for some reason. I don't know why. But this is an incredibly innovative place. And we would love to help you. You help us as well by telling us what it is you need. Right? We're not out there in the trenches with you guys every day. Again, it was a conversation this morning. We got all these things across the campus, but none of them are talking to each other, and I can't figure out where to go to get writing. Right? Oh, it's awesome. That's another, yes, right. So that's a big concern for us, right? How do we actually get around that? This is a huge campus. There's 70,000 people here on any given day when the place is full. So, organizing all of that is difficult. But what we're going to do next is, there's this thing out there, and you've probably heard of it, it's called ChatGPT. But we are going to develop effectively a ChatGPT for innovation, for all of the resources, both on the campus and off the campus. Because everybody, when they come to this, come at it from a slightly different angle. This is why websites are, I'm going to say useless. That's a terrible thing to say, though, right? But, because the website is presented in a particular way, and everybody has a different perspective on what they need. So we're going to actually catch up with the AI era and put all of this stuff in some sort of a ChatGPT type format. So you'll be able to find the stuff that you need a lot easier. As you can see, AI is transforming everything. I think Chris is up next, right? Going to tell us how the world is changing. My world is all AI these days. It's kind of crazy. But again, we are here to help you. Please help us by telling us what it is you need. Don't hesitate at any point to come to any of us, up here or across the campus. We really are here to try and help you achieve the goals that you need to achieve in this innovation program. And so with that, I'll hand it back to Rich. And thank you again, Rich.
Thank you, Paul. Thank you. And, I'll be remiss if I didn't mention a number of people who have helped get this program going. There is a core faculty committee here who will be introduced along the way during the next 2 days. But let me first of all acknowledge Preetham Suresh, who is on the third row here, anesthesiologist here in the medical school. Then we'll be joined by Charlie Goldberg and Scott Mullaney, who are also faculty members who are part of the core team. And then Stephanie Allen on the back. Can you please raise your hand here? She's an entrepreneur in residence after a significant stint in the industry. She's really helped put this together as well. And I know a number of you student volunteers here who have helped me. Last night we were here just getting this set up, and like Paul was saying, it's amazing to see the activity level in this building even at 9:30 p.m. in the night yesterday when you're moving things in. So we're going to get this going. And one of the major developments in the campus in the last 2-3 years is a center called the Center for Health Innovation, and more recently, the Jacob Center for Health Innovation. And based on the vision of Chris Longhurst, who's basically been the force behind this. So I'm really pleased that Chris is going to get us going this morning. And then we're going to go do a deeper dive into some of the innovations happening here. So we learn from that, and also how you could bring some of your innovations through JCHI and get them to market. So over to Chris here. Thanks for joining us, Chris.
Thank you, Rich. Much appreciated, and not to dispute any of Vish's truths, but it's a team effort, and I've got a bunch of health system colleagues here today. Just raise your hands. I want to point out Dr. Ron Belcarry, Heidi, Nicole May, Ashley Gambier, and others who are here representing the Jacob Center for Health Innovation and the health system. So as we were talking about, AI really is changing a lot of things, and it's changing a lot in healthcare, and it's going to change even more. So I wanted to share a little bit about what's going on in the front lines and what it really feels like on the sharp end of patient care. In general, I would say that the forecasting and predictions about what AI is going to do in healthcare in the next 3 years are probably overstated. We have a lot of work to do, a lot of measurement, a lot of evidence to generate. But I think what it's going to do in the next 10 years is understated. I think this is going to be massively transformational from a healthcare delivery standpoint. So how many of you here care for patients? Okay, we've got a few clinicians in the room. For those who aren't, just a little bit of background. Obviously, the UC San Diego Health System is one of 5 medical centers, and we're an essential hospital. We're the safety net hospital. We serve the underserved here in San Diego and across the state of California. And in fact, in San Diego, we're very proud as the safety net hospital to serve an increasing percentage of our region. And we're one of 5 hospitals in the state of California that was ranked by US News as a top 20 nationally leading healthcare system. Now look at those other 4 hospitals. We've got 2 UCs, San Francisco and Los Angeles, and then Cedars and Stanford. And I came from Stanford. I can tell you Cedars and Stanford print money. San Francisco and Los Angeles both exist in regions with county hospitals, LA County and Zuckerberg General or San Francisco General. The only safety net hospital from California on this list, and that's something we should be incredibly proud of. And we are, and the reason we're on that list in large part has to do with the quality of care that we deliver. We're extraordinarily proud of that quality. In fact, Visium, which is a benchmark of academic medical centers, not only are we in the top 5 there, but as Jordan is expressing, we 5P'd it, right? This is the 5th year in a row. And that's harder than just achieving it once, it's sustaining that type of quality. So it's a lot to be proud of. But here's yesterday's patient safety dashboard. When we look at standardized metrics of patient safety indicators, we have over 400 events on an annual basis, more than 1 a day on average, considered by CMS or Medicare to be a preventable patient safety incident. An iatrogenic pneumothorax, a pressure ulcer, postoperative sepsis. And we know this, and every week there's a significant events committee and we review the things that we wish wasn't happening to our patients and what we can do better. And we're not unique. In fact, across the country, this happens. In fact, a study that was done 25 years ago by Dr. Bates at Brigham and Women's Hospital led to the Publication Institute Medicine report To Err Is Human, which famously suggested that about 100,000 Americans die on an annual basis from medical errors. More than a 747 worth of patients going down on a daily basis. And so I was part of this back in 2001 as the patient safety movement really took off. Speakers from across the country, funding, resources devoted to patient safety. And so Dr. Bates repeated that study. It was published last January, just over a year ago. So 25 years after his original study, he repeated it. And what did he found? We've made very little progress over 2 decades in patient safety. So we've got to do better. We've got to do better for our family and for our friends. And so literally the same month that this was published by Dr. Bates, Dr. Klassen and I published this thought piece about how AI might be able to help bend the patient safety curve. And based off of some work funded by Robert Wood Johnson and some private foundations, we had gotten thought leaders together to think about how could we bend the patient safety curve. And we came up with at least a dozen different ways, a dozen different things that we could do that would make a difference. And I'll tell you at UC San Diego Health, we're pursuing most of these. You're going to hear from Nicole and Heidi soon about the Student Health Project, which falls right into that number 6 category. But I want to share 3 case studies today and what that means for the Jago Center for Health Innovation. So the first case study is about chest x-rays. We get around 100,000 chest x-rays on an annual basis in our health system. And I will give you one example of when this was really pertinent, which had to do with the pandemic. Now, those of you who are in San Diego may remember the pandemic here did not start in March with the rest of the country. It actually started in February. So these were the headlines from February 6th and 7th, when we received the first planes with expatriates out of Wuhan. And on February 10th, we got a call from the county who said, we've got a patient who's tested positive, can we hospitalize them at UC San Diego? And without missing a beat, we said, of course, the safety net provider, we're happy to partner. We spun up our command center. We started investing thousands of person hours into processes, protocols, order sets, how we could best care for these patients. And I remember at the time thinking, God, is this going to be another SARS? I mean, much ado about nothing. We don't know. But over the course of 6 weeks, we cared for a number of patients. In fact, one of the first 5 COVID patients in the United States was hospitalized right here at UC San Diego, and our team wrote about that in the summer of 2020. But because of that, on Friday, March 13th, when the White House declared the pandemic, I was sitting in a conference room in Jacobs Medical Center with Dr. Albert Schau, one of our radiologists, Dr. Mike Hogarth from our clinical research team, and others. And Albert was sharing how he had gotten a paper approved using machine learning to predict COVID pneumonia from a Wuhan data set of chest x-rays. And based off that peer-reviewed paper, we decided we want to put that in production to help our clinicians. Now, normally that would be a 6 or 9 month project, but there were no other priorities. And so in 14 days, we went live with that. So 2 weeks after the pandemic was declared, we were the first in the country to integrate a machine learning algorithm for COVID pneumonia detection. That went live on Friday, March 28th. You'll see these press releases. We waited a few days the following week to announce it. But on Monday, April 1st, I walked through the emergency department, and I remember talking to one of the clinicians in the emergency department. I said, hey, have you noticed the color coming back on the chest x-rays? What do you think about that? And the attending physician said, yeah, in fact, just yesterday, we saw a patient brought in from a nursing facility for heart failure. We got a chest x-ray to look at the heart. She didn't have any respiratory symptoms, but it showed some color in the lungs. We talked to the radiologist. He didn't see any pneumonia, but based off the AI, we decided to order a COVID test. So, shit, what did it show? So I don't know, it takes 24 hours to come back. So we looked it up together. I was standing over her shoulder as she logged into the electronic health record. And sure enough, it was positive. So you can imagine I followed that patient quite closely, as did our outpatient COVID team. She did start to develop symptoms, and we hospitalized her proactively earlier than we would have otherwise, right? She did very well. She never needed mechanical ventilation. She didn't go to the ICU. She was discharged back to the nursing facility healthy. And it was a clear sign of how AI could help us better care for patients, right? But it was also anecdata, right? It was a narrative, but it wasn't quantitative. And so that's when we partnered with Dr. Christian Demeth in the emergency department. We said, well, let's study this. And so over the course of the summer, 2,000 patients in the emergency department had chest pneumonia. And we asked every single physician, resident and attending, caring for those patients, did it help you? What did you think? Did it make a difference? And 1 in 5 cases, it changed clinical decision-making, which is an extraordinary finding for the summer. 1 in 5 cases. Now, one of the things we didn't publish in this paper, but we saw clearly in the data, was there was an extinguishing effect. Over the course of the summer, it actually became less valuable. Why was that? Because by the fall of 2020, testing had become ubiquitous. Right? And everybody stepped foot in the emergency department got screened. And so it was no longer as helpful. In fact, we turned this AI off at the end of 2020, which illustrates a really important point, which is the importance not only of reviewing a governance around implementation of AI models, but also monitoring it on an ongoing basis for its utility, safety, efficiency, and equity. But the most important point here that I wanted to illustrate is that we studied it. In fact, just last year, a review article came out about all the studies published on COVID and AI. And Vish, there were 9,000 studies published over a 2-year period. 9,000 research articles that had the term COVID and artificial intelligence. And this review article looked at how many of those actually measured clinical outcomes. And the answer was 4. There were 2 internationally, 1 from Israel, 1 from Saudi Arabia, 2 domestically. And this study by Dr. Demeth was one of those 2 articles, right? So it's great Dr. Demeth was cited. We're proud of the fact that we're evaluating these outcomes, but there's a real paucity of evidence around AI. There's a lot of papers being written about the algorithms and the predictive value, things like that. But as I'll share in a minute, I'll take a less predictive algorithm any day if it actually is making an impact on clinical outcomes, right? So another area that we brainstormed would be an opportunity to help was around real-time dashboards. And of course, that's something that we leverage with a lot of tenacity around our health system. On a daily basis, as an executive, I get 3 or 4 dashboards, including our daily bed capacity, where we predict out our bed capacity based off of patients in the emergency department who've been admitted and surgical cases scheduled that may need admission, average length of stay, and things like that. And for years, we had a formula to do that. And the formula was okay, but not great. And so the team then put together a machine learning model. It's not, like God's gift to machine learning models, but it's a good one. And we ran it side by side with the formula for about 3 months. And the entire organization was really clear, machine learning algorithm did way better than the formula. And so we replaced it. We sunset that old formula we've been using forever. And now on a daily basis, every single one of our executives looks at the AI prediction over the next 4 days for patients in our emergency department. And we make real operational decisions. This week, we've had so many orders that we've stopped adding on cases in the ORs because we hit a threshold based off of our ML forecast. And so we actually have over 25 or 30 ML models now in production where we're using this to predict readmission likelihood or risk of mortality or insurance denial or all sorts of things. And it's more accurate than the models that we used to use. Another very popular area is sepsis prediction. And you saw our post-operative sepsis data a little bit earlier. We do very well overall, but we can do better. CMS and our patient safety leaders consider post-operative sepsis a preventable patient safety metric. We should be able to identify it. In fact, there was a campaign, the 5 Million Lives campaign that launched 7 or 8 years ago about identifying sepsis. And yet every day, in every hospital across the United States, sepsis is missed. Can AI help us? Absolutely. In fact, Vish, 10,000 articles have been published in the last couple of years on sepsis and AI. It's the most popular machine learning algorithm for publications. How many of those have actually been implemented clinically? About 28. How many of those have shown impact on mortality? Well, until last week, there was only one. It was a study out of Johns Hopkins. And then last week, Dr. Gabe Wardy and Dr. Shamim Namadi from UC San Diego Health published this article, where they found an almost 20% decrease in mortality in our patients, in our emergency departments, at the associated with the implementation of our AI-based alert. Now, I'll tell you that Dr. Shamim Namadi came from Emory, and he was already a very well-known sepsis AI researcher. He had BARDA grants with the DoD, and he was studying large data sets, how to predict sepsis. And one of the things that excited him about coming to San Diego is we said, we don't want to just study algorithms. We actually want to study outcomes. We want to implement. We will help you implement your algorithms here. This is attacking what Dr. Karndeep Singh calls the health AI paradox, which is that researched AI algorithms are not implemented, and implemented AI algorithms aren't researched. And so we're trying to close that gap. But one of the interesting things Shamim will tell you is that despite all the papers and grant money he'd gotten around sepsis AI, he learned more in the first year coming to UC San Diego than he had before. Why? Because he sat on the hospital sepsis AI committee, the hospital sepsis committee. Dr. Wardy, emergency department clinician, chairs our sepsis committee. Shamim sits on it. And he started learning about the workflow and the process and the challenges of who do you alert and what's the right time in the workflow to ask for additional labs. And how do you do that without overwhelming the end users? If you look at the research in sepsis AI, there's all these studies about, my algorithm's 98%, your algorithm's 72%. But it's missing something really key. In fact, Dr. Singh published a famous article out of Michigan that discovered that the vendor-supplied sepsis algorithm they were using actually used the administration of antibiotics as a predictive factor for predicting sepsis. Well, guess what? By that point, it's too late, right? That's a worthless algorithm. I don't care how predictive it is, right? So I will take an algorithm any day that's 20% predictive if it's 6 or 12 hours before the clinicians have thought about sepsis developing, right? So there's a lot of nonsense going on about algorithm performance that ignores the reality that 80% of the hard work is in the workflow. That's the secret sauce of using AI to impact health AI outcomes. And so we're very fortunate that we have a code team that also functions as our sepsis team. And so we're able to alert not just the end users, but also that centralized team. And if you read this paper that Dr. Namadi and team published last week, you'll see that there's a lot of plausibility around this association, because when we implemented the AI algorithm with these workflows, compliance with our sepsis bundle increased. Early administration of antibiotics increased. So is that going to impact mortality in a meaningful way? Absolutely. And so that's really what we're interested in. Those 3 case studies are about ways that we're implementing AI and machine learning algorithms and measuring the impact on care. Again, addressing that health AI paradox, Dr. Goldberg, that implemented algorithms are rarely researched, and researched algorithms are rarely implemented. In fact, this is a study not by us, looking at thousands of studies on AI in healthcare. And as you can see, the bulk of them are right there in lanes 3 and 4 about model prototyping and model development. Look at the paucity of studies on clinical outcome evaluation. With 10,000 studies published on sepsis and AI, 28 looked at clinical outcomes, and now 2 have shown an impact on mortality. And so I hope those case studies really illustrate the focus that we have in the health system, and that's really what led to the founding of the Center for Health Innovation. And you can see our mission statement here is innovation at scale with impact. In fact, we uniquely sit as a center inside the health system, not the School of Medicine, because our goal is not about publishing papers or getting grants. Our goal is about solving real-world problems in the health system. Now, we're going to publish papers as a byproduct, and I think we're going to get a lot of grant money. But we report to the executive committee of the health system. In fact, we're going there next Tuesday to talk about how we're helping. And in fact, our logo for the center is a visualization of this bridge, because the bridge was not only physically helpful, everybody lives over in East Campus getting over here, but it's metaphorically really significant, because it used to take me 20 to 25 minutes to get to this building. And now I can walk over from the hospital. Not today because it's raining. And based on some of the work that we were doing, we were super grateful to Dr. Irwin and Joan Jacobs for their very generous donation. They created the now Jacobs Center for Health Innovation. And we actually launched this publicly last May with a fantastic symposium. You can see Irwin and Alexano, Pradeep and I, and our CEO, Patty, talking to the robot from Mashani. It was a fantastic way to kind of kick this off. But I'll tell you that Paul Sisson's headline in the San Diego Union Tribune got it right. He said, this generous donation will establish a mission control center to manage emerging AI. And those really are 2 of the most critical swim lanes for our center. So the first is about emission control. And you're going to hear more in a minute from Nicole May about our work to establish a command center in the health system. And this command center is going to be focused not only on helping us with challenging patient flow. You might have heard we bought a hospital. You might have heard we're about to buy another hospital. So this now 4-hospital system, we need to manage patient flow across 4 different health systems, 4 different locations and hospitals. But also across all of our clinics in the region and across all of our patients at home. And we're excited about how this mission control will help us with that. But I'm also excited about the fact that just like that sepsis alert, we're gonna have a centralized place where we can deliver AI augmented information to the right people to make the right decisions at the right time. Not just to our frontline clinicians, but also to a system of care that's ensuring we're providing the safest possible healthcare in the country. Now, I mentioned the patients at home, and this is related to a really important project that the Jacobs Center for Health Innovation has been catalyzing. So it started several years ago with what we call P1000. It was an effort to get remote patient monitoring off the ground. And again, lots and lots of papers from lots and lots of hospitals about the 22 patients that they have that are remotely monitored. We said we want impact at scale. And so P1000 was an audacious goal to monitor 1,000 of our patients, largely Medicare patients, in their home setting. And by the time we came back to Dr. Jacobs' advisory committee to report out, we had 1,300 patients on. And in fact, we have data in press now showing that our patients with hypertension had a statistically significant drop in their blood pressure, which is consistent with a lot of prior publications. We have data showing that our patients with diabetes, for whom we were doing digital health remote monitoring with care management protocols to intervene at home, not waiting for their 3-month visit, had a statistically significant drop in their A1C. Again, consistent with prior data, but we're doing the right thing for our patients using these technologies. And as we scale this up, because we're now becoming P10,000 with our new goal, we're going to need these AI algorithms to help us to sort through all of this data. Today, our care managers in the Population Health Services group care for about 250 patients per care manager. But with the right algorithms and the right dashboards and the right workflows, we can probably scale that to 1,000 patients or more. So we're proud that we've served over 5,300 patients. We currently have 400 patients on remote monitoring. But these devices aren't all perfect. We're using a lot of consumer devices, blood pressure cuffs, and other things. But if you talk to our clinicians, there are a lot of other data that they'd like to get at home in a consistent and continuous way. And this is one of the areas where we're really excited about a partnership with Dr. Pisano and the Jacobs School of Engineering, because his teams are looking how to develop clinical-grade wearables that can be worn continuously with long battery lives to help us monitor things we may not have been able to do outside the hospital before. And as the School of Engineering makes these devices available, we can help trial these devices and help develop the outcomes data. In fact, partnered with Dr. Kevin King today with a really innovative monitoring device that goes under the bedpost. And it's so sensitive, not only can it pick up respiration at night while patients are sleeping, they've actually developed something new because it can pick up an electrocardiogram equivalent. They call it a ballistic cardiogram. It can feel the heartbeat. And so those type of devices that we now have deployed in some of our UC San Diego Health System patients are helping us better care for our entire population. Now, deploying AI is exciting, but it's not without risk. And the last thing we want to do would be to introduce unintended consequences, right? We don't want to exacerbate underlying disparities. We want to implement in an ethical manner. And so 4 years ago, we actually stood up an AI governance committee, co-chaired by Dr. Amy Siddipati, now our Chief Health AI Officer, Dr. Karndeep Singh, helping chair this. And they've had a set of principles by which we adhere. These are publicly available. To scan the QR code there. And they come from lots of sources. I mean, there's no shortage of AI principles. A lot of these are what I would call applehood and mother pie. Takes a second. We developed these as a combination of the University of California AI principles. The federal government recently released a set of principles called FAVES, that AI in healthcare should be fair, actionable, equitable, safe. And so it's evolving. But one of the things that we're really proud of there is that penultimate one, transparency. And so let me tell you a story about an AI algorithm that we recently implemented in a transparent manner. So of course, everybody's talking about large language models. And last April, I was privileged to be part of this study that was published and is heavily cited. You might have heard about it because the clickbait headlines said that the chatbots were not only higher quality, but more empathetic than the doctors. Now, I'll tell you, that wasn't my takeaway from this article. I was one of the 7 reviewers rating the 200 responses. Of course, these doctors that were posting, responses on social media didn't know that their, responses were going to be measured and graded against the chatbot. And this was pseudo-blinded, but it was really easy to figure out which was which, because in the spreadsheet of all of the questions and responses, if the response was 2 or 3 sentences, it was clearly a doctor. If the response was 2 or 3 paragraphs, it was clearly a chatbot. And in fact, if you read this paper carefully, that's what you'll find, is that the chatbot responses were 2 to 3 times longer than the physician responses. So were they higher quality? On average, they were, yes. Would I put up any of my doctors against chatbot any day in terms of quality and empathy? Absolutely, if they knew they were being measured and they had an hour to write that response. The real headline here is that in a limited, resource-constrained amount of time, the chatbot could generate high-quality, empathetic responses, but it wasn't perfect. And in some cases, you saw that overlap where the chatbot did dumb things, right? Hallucinated responses. But even before this was published, I started talking to our vendor because this clearly presented an opportunity for us. Across the country, we've had an epidemic since the pandemic of increasing virtual care, right? We provide 10 to 15% of our visits still today by telemedicine. And with that has come an increase in asynchronous messaging. And we want to respond to our patients between appointments, right? But we're not reimbursed for it, and it takes extra time. And so you see all sorts of strategies in the news, like charging patients to message their doctor. And we haven't undertaken that. But we saw this as a potential tool to help. And so as a result of the work that we are doing, we became the first in the country to implement ChatGPT inside of Epic. My old institution, Stanford, was about a week behind us. And Wisconsin was the third in the pilot as well. But we learned a ton last summer about putting large language models inside clinical workflow. The first and most obvious was the prompt engineering. We spent a lot of time trying to get the prompts right, to get the best possible responses, and we worked with Stanford and Wisconsin on that. But the second is the workflow, and this is a real snapshot of Dr. Marlene Millen's inbox, and put yourself in her shoes for a minute, what it feels like to be a primary care physician. When you're seeing patients one afternoon, and at 1:19 p.m., while you're seeing a patient, you get a message from another patient about their asthma. And then at 1:21 p.m., you get a message from a patient about their results. And at 1:22, you get a message about their sore throat. And at 1:23, a work letter. And at 1:24, a message about coughing. And in between patients, you're trying to answer the messages, but really mostly at the end of the day, after hours, right? So with the large language model integrated inside the workflow, we're now drafting a response. And notice there's only 2 buttons there. Start with draft or start blank reply. There's no button that says just send. And that's because one of our principles is keeping a human in the loop, right? There are times when the chatbot gets it wrong, and it's important our clinicians are reviewing it. But a really interesting conversation that we had with the AI governance committee before putting this in was how transparent should we be with our patients? Our principles, transparency. And so uniquely, we did something that Stanford and Wisconsin did not, which is every single message that was drafted with a large language model and went out to a patient came with a addendum that said, this message was automatically generated and edited by the name of the clinician. Wall Street Journal picked up on that. They were really interested. They said, well, what's the response that you've gotten from your patients? And the response we've gotten is overwhelmingly positive. In fact, some of our patients give us feedback like, I know my doctor's busy, I'm reluctant to send them messages. I'm really glad to hear that there's these tools that help us. In fact, after the Wall Street Journal article was published and Dr. Millen was prominently mentioned on the front page, she got a message from one of her patients that said, Dr. Millen, really glad to see that you're using chatbot. I wanted to be the first patient to send you a chatbot generated message so you can send me a chatbot generated reply. So what are we finding with this? Well, remember, I thought we were going to save time. I was wrong. Dr. Ming-Tai Seals helped with an outcomes analysis. In fact, with an IRB exemption, Charlie, we randomized our clinicians to be early or late adopters of this so that we can compare outcomes prospectively. QI experiment. I think one of the first at UCSD. And our early findings, not yet peer reviewed and published, hopefully will be accepted soon, just submitted a revision, is that we didn't save time. It turns out, before the chatbot, it took about 30 seconds for a doctor to read a message, start with the blank screen, type a sentence or two, use a dot phrase, use a macro, etc. After the chatbot, it took about 30 seconds to read the 3 paragraphs from the large language model, make sure it's accurate, maybe edit it a little bit, and send it. So it turns out it's not a time saver for patient messaging, at least not in our study. And I can tell you the early Stanford data is similar. But our clinicians love it. Why? Because it reduces cognitive burden. It turns out it's a lot easier to edit a draft response than it is to start with a blank screen. And our patients like it. And on average, the responses we're sending the patients are 2 to 3 times longer than they were before, which, if you believe that earlier study, suggests that they're higher quality as well. And in fact, anecdotally, we're hearing that. So this is the type of stuff that I had the opportunity to share with some of our policymakers when I was called to testify at Congress on Health AI last fall and was part of the White House committee that reviewed that statement President Biden put out December 13th. We've got to implement AI in a safe, respectful, and trustworthy way. We need principles and governance to help us do that. And things like National Health AI Assurance Labs are going to be helpful for ensuring that algorithms don't exacerbate implicit biases. They're going to be helpful for ensuring that algorithms are reproducible. But they're necessary and not sufficient. The real hard work here is the implementation at the sharp end of care. The algorithm is 10, at most 20% of the work. 80% of the work is the process redesign and the hard work that Ashley Gambir's team and others do to actually put these into workflow in a way that make a difference. So that's what the Jacobs Center for Health Innovation is all about. And I know I'm going to hand this over to Nicole and Heidi and Carnby to tell you more about it. But thank you very much, Fish, for the time.
Thank you, Chris. As always, a beautiful talk. We may have time for a couple of questions.